So dealing with a grossly subluxated nucleus can be a challenge even in the most experienced of hands. Thus, understanding the principles, the options, and the technique of fixating these grossly subluxated nuclear complexes is very important in achieving an optimal outcome. Now, when you're looking at subluxated cataracts, now it could either present to you preoperatively, wherein you have enough time to do a thorough workup in the form of a UVM to figure out how much is the extent of the subluxation. As opposed to this, when you have intraoperative subluxation, the story is different. This is an unplanned procedure. There's no way you can figure out how subluxated your bag is. And therefore, now you're a question as to what to do. There's no pre-op workup. You don't know how bad is the subluxation, and you cannot therefore evaluate what is the extent of the subluxation. I'll now share with you what I consider the 10 steps of getting to a proper and doing a proper scleral fixation of a capsule tension segment in a patient with a gross intraoperative subluxation. So the first point is to evaluate what is the extent of the subluxation, which again I told you can do it preoperatively or figure it out intraoperatively. Once you have defined what is the extent of the fixation, the subluxation, you then need to define, okay, this should be the clock hour of the fixation. So once you've decided, now how do you know which is the point you want to do the fixation in? When you look at the area of subluxation, you figure out, okay, it's between 6 and 9 o'clock. So it's 7:30. The midpoint of the area of apparent subluxation of the bag is what you decide as should be the point of scleral fixation. Now you want to make your scleral flaps. Aesthetics to me as a surgeon is important. So I was drawn to the idea of a Hoffman Pocket. Now how is this made? Okay, so you take a guarded depth blade, I've not used it here, but a 300 micron guarded depth blade to make a clear corneal groove in the peripheral cornea as seen here. From here, you now fashion a reverse scleral tunnel. And when you fashion this reverse scleral tunnel, you're aiming to make a 2 by 2 millimeter scleral pocket. And as you can note here, now you no longer need to raise the conjunctival flap. You no longer need to make a scleral flap either. You make a scleral pocket. I like to do it at the initiation before entering into the eye because now I have a nice taut eye to work with. Now having done that, now you have to proceed with the rest of the cataract first. I'll talk to you about this very briefly. Now, when you are doing a capsulorhexis in a grossly subluxated cataract, one problem is that often it's very difficult to even initiate. The reason that happens is because you do not have adequate stretch of the anterior capsule. You don't have an adequately stretched capsule. Once you've created the initiation, sometimes you actually find it's a drag on the capsule. It's even difficult to propagate it. So therefore, make sure either you use a microrhexis forceps or make your 2.8 to allow for entry of a Utratus forceps. And when you're actually doing it, can you see? You actually see rocking movements of the nucleus as well as you can see folds on the anterior capsule. The next step is the use of capsular hooks. It's advisable to use capsular hooks to stabilize the capsular bag before doing phaco emulsification. The number of hooks used in this particular case depends upon clearly the extent of the subluxation. Now these hooks, Grease-Shaver hooks, we often ETO and reuse. But reusing these hooks to fixate the capsular bag can be a problem. Look at this hook here, the one on the left which I'm putting in now. If you do not have an adequate bend, there is a tendency for it to flop out of the capsular bag, thereby taking away its thing. I'm sorry. Now, this is what we learned. Now, suppose you have a gross intraoperative subluxation and all you do is put in hooks and then say, okay, I'm going to go ahead with my phaco. Remember, we are not aware of how subluxated the bag really is. So if you were to proceed with your phaco emulsification, downsizing the nucleus and emulsifying the fragments, you might find if it's a very, very gross subluxation, as the fragments get less and emulsified, the entire bag can actually get sucked into your phaco probe because you do not have an equatorial stretch anywhere at all. Okay, so in these cases, what you do is you put in your hook and now you stabilize and stretch the capsular bag by putting in a CTR to give you a stretched capsule which allows you to do it. Now, I won't go into the details of phaco. I'll just tell you, we do a phaco with minimum manipulations, always a CTR before doing the hydrodissection because you want a stable bag even during a hydrodissection procedure. The phaco should be done with either a hydroprolapse and chop or just a or just a chop in situ, not too much of turning, because anything is going to make matters worse. Cortex removal, sometimes slightly a bit of a problem because it gets trapped, and place the IOL with minimum manipulations. Why? So before coming to the CTS, I like to keep an IOL in the bag always, because one, it offers protection to the posterior capsule when the needles are going in, and two, it allows for centration of the CTS when you're tightening your sutures. The next thing that you can do is have iris hooks. Now, the extreme iris hooks in this picture here are holding the capsular bag open. This is my proposed site of fixation. But having iris hooks at the site of the iris as well, retract the iris, that's not a bad idea because it gives you visibility at the area of your fixation. Now we come to the most important part, which is fixating the capsule tension segment. Now, a capsule tension segment, easily available, comes in sets of 2, is made of PMMA, and it is an arc of about 180 degrees. I'll show you the video which demonstrates to you, having done all this, this is the step you come to now. So this is your capsule tension segment. It's got a central loop with an anterior elevation. The anterior elevated part is always superior and anterior, and a central eyelet. One needle of a double arm Prolene suture passes through the eyelet, making it ready for fixation. The needle now, from wherever you're sitting, enters into the eye, and with the help of a 26 gauge needle, is exteriorized. It's railroaded with a 26 gauge needle. It is now exteriorized and comes to lie at a point opposite the area of subluxation. Then you put in the capsule tension segment, and it is introduced into the capsular bag at the proposed site of fixation. The second needle is now introduced into the eye and exteriorized in much the same manner as was the first. So now you have your CTS in place, you have your Hoffman pocket, you have the looped eyelet of the CTS, and both needles on the opposite side. At this point, I now release the capsular bag hooks. Why? Because I want space for my 26 gauge needle to go through. Now this 26 gauge needle is introduced into the eye at the site of subluxation within the confines of the Hoffman pocket, 1.8 millimeters behind the limbus, to enter through the supracapsular space into the anterior chamber. One of the needles is now railroaded through this 26 gauge needle and exteriorized to come to lie outside. It's pulled out, drawn out, and now comes to lie outside. This procedure is now repeated. A needle is now introduced adjacent to the first place, the 26 gauge needle, back into the anterior chamber. The second needle is now feeded into it and railroaded out to come to lie 1.8 millimeters behind outside, as demonstrated here. Now both your needles are out. Now the capsular bag hooks, which are just lying around there, leave them alone. The cut ends of the needle are, the needles are cut, the cut ends are left long. Now the two free edges of the suture are drawn out to lie at the limbus, and the suture is now tied. The extent of titration, how do you extend the extent of tightening of the knot, is titrated by the centration of the IOL. Let that be the guide to tell you, because you can't exactly see the capsular bag edge in the periphery. So go by the IOL centration and then tighten your suture. After this, I guess the viscoelastic is washed out, you confirm centration of the pupil, and you hydrate your wounds. And this largely would be the end result. Now, what I've learned along the way is, one, we used to use straight needles. Alcon now has the curved needles that come. The problem with the straight needles is that it can cause a problem intraoperatively. While you're pulling the needle out of the eye, the posterior end can actually push backwards and damage the posterior capsule. So one thing I learned is that move to curved needles as opposed to straight needles. And the second thing I learned, now if superior is the area of subluxation, if you go directly in with the straight needle through the area of subluxation, through the supracapsular space, and try to railroad it on the opposite side, it can be technically quite challenging. Therefore, I advocate the technique that I've shown you earlier. And I'd like to end by giving you this little bit of advice which I've realized along the way too. Sometimes you may have misdiagnosed what is the extent of the subluxation. So this is actually a IOL suturing video, but similarly, if you end up suturing one of the capsule tension segments, you might actually find, as you can see here, the other end is also subluxated. So you have to be prepared for the same, that okay, I thought I need just one, but I need another. So make sure you have at hand another couple of needles, because sometimes they can break, an extra CTS, a well-blocked patient, accessible, and enough energy to actually see this through. So if I were to sum up how you were to do a CTS, segment fixation, in a patient with a subluxated IOL, this is how it would read. First, assess the extent of the subluxation, decide what is the point of the fixation. Before entering into the eye, make a Hoffman Pocket. Go ahead with your capsular X's, put in your capsular bag hooks, put in a CTR, do a Phaco IA with an IOL, release the iris hooks, do a CTS fixation, and check for stability of the opposite side of the bag, second CTS as and when required. With that, I come to the end of my talk. Thank you very much.